So today we will learn about the developmental anomalies of the genital tract. So as you know, the embryology is there is two different entities, right? There is a gonad, so there is a gonadal sex differentiation, and there is a duct, reproductive ducts, okay, reproductive tract. So there is a ductal sex differentiation. So there is it was Johannes Peter Muller in 1830 was the first to describe the female genital duct that develops as uterus and vagina. So that is what is known as the paramesomorphic duct now, but after him it was historically named as a Mullerian duct. So it is the paramesomorphic duct from either side which comes and fused to form the fallopian tubes, the uterus, and the upper 2/3 of the vagina. So this is what we are going to talk about in the class today, the problems with the fusion and what all abnormalities can happen. So that is why the embryology is important there. So that is your bipotential stage of the gonad. As you can see, at 6 weeks of fetal development, the internal reproductive organs have the potential to develop into male or female structures. This is from your embryology days. This is a bipotential stage of the gonad. It can develop into the male or the female. So what determines whether it develops into the testis or into the ovary is your SRY gene on the Y chromosome. On the short arm of the Y chromosome, you have something called the SRY gene, which is the sex determining region of the Y chromosome. And that is what decides whether this fetus has to grow into a male or a female. That starts producing by 10 weeks the SRY protein in the male directs the bipotential gonad to form the testis, and the testis starts. So up till then you can see there is a bipotential gonad. Then you have the Mullerian ducts, which is the paramesomorphic duct. Then you have the Wolffian duct, which is the mesomorphic duct. So the Wolffian duct or the mesomorphic duct is a male duct, and the Mullerian duct or the paramesomorphic is a female. Towards the going to develop into your female genital tract. Okay, along with that you can see the metanephros, that is the development of the kidney, and the bladder, and the bladder opening into the cloacal opening. So you can see that this whole, both the systems, the urogenital system develops in close relation to each other. Okay, so what happens in the male, like we said, if there is an SRY protein is produced, there is a Y chromosome, SRY protein is there, and that directs the gonad to form into the testis, and from there testosterone as well as the Mullerian inhibiting factor, or the MIH, Mullerian inhibiting hormone, is produced. So the Mullerian factor, the Mullerian side, the Mullerian ducts degenerate, and all the male factors, the male ducts start developing. That is a Wolffian duct develops into the male ductal system. If there is no SRY gene, so if there is no Y chromosome, what happens is the bipotential gonad develops into the ovary, and from there the ovary, there is no testosterone or Mullerian inhibiting factor, so there is a Mullerian duct develops into the fallopian tubes, the uterus, and the upper 2/3 of the vagina. And what happens in Wolffian duct, largely it degenerates, with some remnants might be there here and there. Okay, so that is what happens in the adult stage. So this is another picture depicting the two halves. The left half is developing, the testis develops, and you can see the Wolffian duct develops in the epididymis, the vas deferens, and all that. And the right half depicting the paramesomorphic duct development, that is a Mullerian duct development, where you can see when the ovary has developed, there is no testis, the ovary has developed, then the paramesomorphic duct is the one that develops into the oviduct, which is a fallopian tube, and that fuses, and you can see that you can see the uterus forming in the midline. From either side it should come and fuse, and the uterus is formed in the midline, and the upper 2/3 of the vagina as well. So this is to show how it comes from both the sides. The Mullerian duct comes and starts fusing, as well as it opens to the urogenital sinus. So the urogenital sinus, that area will form the sinovaginal bulbs and will develop into the upper 2/3 of the vagina. And fused part of the two Mullerian ducts will start developing into the uterus and the cervix. And the unfused upper portion is going to remain as your fallopian tube. So this is the whole what your Mullerian duct is going to form into. So about 8.5 weeks, if you see, this is how this is another 3D kind of picture, where you can see the Mullerian ducts coming in, opening into the Mullerian eminence in the urogenital sinus. So it is going to form into the upper 2/3 of the vagina. So the two paired Mullerian ducts ultimately develop into fallopian tubes, uterus, cervix, and the upper 2/3 of the vagina. The trigger, as we said, is the absence of Mullerian inhibiting factor. There is no testis, means there is no Mullerian inhibiting factor, and so it develops into the Mullerian tract. Now, there are three phases of development. One is organogenesis. So, the Mullerian ducts may not develop fully sometimes. See, even in the absence, even if there's no testes, even if there's no Mullerian inhibiting factor, even if it is an XX chromosome, there's no Y chromosome in it, there is no ovary forming. What happens is sometimes the Mullerian duct as such may not develop properly. It can be unilateral or bilateral. So, depending on that, it can be uterine agenesis or hypoplasia or unicornuate uterus. So, that's a problem with the organogenesis. The second problem can occur in the fusion. So we said that the two ducts will form, will have to start forming, and then they come in the midline and fuse. Part of it, the caudal end of it fuses to form the uterus, the cervix, and the vagina. So the fusion doesn't occur properly. It can be lateral fusion problem, or the or it can be vertical fusion. So where it is fusing with the sinovaginal bulb, there can be a problem with that. So there's a vertical fusion defect. There is a there can be an imperfect hymen, because the vertical fusion it comes and fuses with the sinovaginal bulb, and that is what is going to form into a vagina. And the lateral fusion defect failure will result in a bicornuate or a diadelphys uterus. So the septal, now the third phase of it is septal resorption. First is organogenesis. Next, it has to fuse. First, the ducts has to form bilaterally properly. Then they have to come in the midline and fuse. That is, a lower end part of it has to fuse together and form those three, your uterus, cervix, and the vagina. And third thing is, once they have fused, the septum between has to get resorbed. Only then it's going to be a normal functioning uterus and vagina. So the central septum subsequently must be resorbed to form a single uterine cavity and cervix, and the failure of resorption causes a septate uterus. Now, what can the etiology be? Largely, actually, it is vast majority is due to polygenetic and familial factors. But the etiologic factor as such, which has been described, is one substance that has been known to cause Mullerian anomalies is DES, or diethylstilbestrone, which was used in the 1950s and 60s. It was a estrogen. It is a synthetic estrogen which was used to be given to women to prevent preterm labor or threatened abortion. They used to be treated with DES, and then they later found that women who got DES, their girl children, their daughters, ended up having some Mullerian abnormalities, as well as they were at high risk for adenocarcinomas. Okay. So theoretically, teratogenic interference by any agent during the developmental period of 6 to 10 weeks of gestation. That is the time we said that bipotential gonad and all the both the systems, Wolffian and Mullerian systems, are developing at that time. So that any insult at that time can influence any of the mesodermal systems. Any of the mesodermal systems. So everything, all these things, the urogenital system, the whole thing, kidney, bladder, everything is developing from the mesonephros. Now, the true prevalence and incidence is difficult to assess, because one thing is, some of them are not present with anything at all. So only the ones who present with some kind of complication or some kind of problem only comes to the notice. Anyway, general population, as well as there are a lot of different types of classification systems used to be existing. So the general population may be about 0.5 to 1, or maybe more than that might be, there might be the prevalence of Mullerian abnormalities. In fertile women, 2 to 3%. Infertile women, 3% or more. In women with repeated miscarriages, about 5 to 10% might have a Mullerian anomaly. Now, the distribution, what are the types of Mullerian anomalies? We said there can be bicornuate anomalies, bicornuate uterus, septate uterus, didelphic uterus, arcuate uterus, unicornuate uterus, hypoplastic forms. Okay, so of these, bicornuate is the most common, about 39%, followed by septate uterus. Now, the presentation at what age? So, they can be diagnosed at infancy, adolescence, or young adulthood, depending on how they present. So, sometimes it might not be, we will not know about it until she, comes to you with infertility. Everything else might be normal, then she might present to you as an infertile woman, or maybe she will come to you with repeated miscarriages, or sometimes she might present to you in infancy with certain problems. So, what can those be? Okay, if it is an obstetric population, in obstetrics as such, what are the complications due to Mullerian anomalies that you can find? One is repeated abortions, because the cavity is reduced, right? Because the anomalies, there can be hemiuterus. We said proper fusion is not there, or proper resorption is not. The cavity size is reduced, so there is more chance for repeated abortions. Cervical incompetence. Again, the structure and function of the cervix is not going to be properly formed. Then the preterm labor due to the small cavity. There is more likelihood to go into preterm labor. Intrauterine growth restriction due to one small cavity, as well as due to the, especially in the septate uterus, the septum, if the placenta gets implanted partially onto the septum, or fully into the septum and all. The septum is not a very vascular area unlike the rest of the uterus. So the blood supply to the placenta will be compromised there and they can come with IUGA. Abnormal fetal lie. Now, that is what is abnormal fetal lie? What are you talking about? Breech and transverse lie presentation. So, always when we do a cesarean section for a breech or transverse lie, when we're doing that, we always check the uterus to look for anomalies. Just to know, just to document what anomalies. It's not a problem because they have conceived. Only thing is, it is a malpresentation, so they may not be able to deliver normally vaginally. No, but when you examine those uteruses, when you see it intraoperatively, you might pick up some abnormalities. Okay, then sometimes some of them might present with dystocia at delivery, especially because again it's a developmental problem, right? So depending on the structure and function of the cervix and the lower uterine segment, how it is formed. Then some of them might present with retained placenta. This is again because there may be two, the placenta might get trapped in one of the horns. If it's a biconate uterus or if it's a septate uterus, it might just get trapped and it is not going to get expelled by the normal contractions of the uterus. Apart from obstetrics, they can from the obstetric complications. Sometimes even before a woman becomes pregnant, she can present with certain gynecological problems like infertility. Like I said, many of them you might be picking up because they're coming for infertility treatment. Then you will find that there is a uterine abnormality or dysmenorrhea. Now, dysmenorrhea is due to, especially there is a collection of blood somewhere. You know, the cavity is not formed properly. There is no place for the menstrual blood to flow. So there is a collection forming inside one of the cavities. Okay, or obstructed or partially obstructed Mullerian systems where they can be varying. Like, you know, when you talk about dysmenorrhea, it will be cyclical dysmenorrhea. It depends on where the obstruction is, so and whether it is partial or complete obstruction, how they present. So they can come with hematosalpinx, that is blood collected in the tube, or hematocolpos, that is blood collected in the vagina. Hematometra is when there is blood collected in the uterus. So that will be the last stage because the uterus is more muscular organ. So the distendable organs are the fallopian tube and the vagina. So depending on where the obstruction is low down, mostly it will be a hematocolpos because the vagina is very distensible, it will keep distending. If the obstruction is there in the cervix, then the backflow, because of the backflow of the blood, it is the hematosalpinx is very likely to happen. And retrograde menses can occur, and because of that, endometriosis. Now, renal anomalies, because we said that both the systems develop in close relation with each other. High association between Mullerian duct anomalies and renal anomalies, like unilateral renal agenesis. Now, classification, according to this is the most the popular classification, the American Fertility Society classification. There are 7 classes. We talked about, in the beginning, we talked about the 3 phases of development, right? One is the organogenesis, second is the fusion, and third is the resorption of the septum. So class 1 is the organogenesis problem. So there's not proper genesis, either hyperplasia or agenesis of the Mullerian systems. And of this, the most common form is the MRK syndrome, where there is combined agenesis of the uterus, cervix, and upper portion of the vagina. Patients have no reproductive potential aside from the medical intervention in the form of IVF. That is, if they have a properly formed uterus, uterus which can support their pregnancy. If that is not there, if it's a very infantile uterus, even that may not be possible. I mean, if it is, so that IVF has to be on a they have a normal ovary. It's just that the Mullerian system is not developed. So you can do an IVF of the ovum from the mother and get it implanted onto a host uterus. Okay, the differential diagnosis would be a testicular feminization syndrome, because in both the cases it will be a phenotypic female, but in case of testicular feminization syndrome, it's a genotypic male. So there the problem is that testosterone does not act. It is produced, but the receptors are not there, or there's an enzyme deficiency and problems like that. So testosterone cannot act, so develops into a female phenotype. But again, the Mullerian inhibiting factor is present there. That is acting. So it is not going to develop. The Mullerian factor is not going to develop. It is not an ovary. It is a testis in a testicular feminization syndrome. Whereas in MRKH syndrome, there is no testis. It is the ovary. It's a genotypic and a phenotypic female. Only problem is there is a problem with the development of the Mullerian duct system due to whatever reason. But whatever the function of the estrogen will be there. So it will develop into a phenotypic. She will develop into a phenotypic female only. Phenotypic and genotypic female. So that differential diagnosis is important. So generally, we either you have to do a karyotyping to know the sex, or MRI will show you some remnants of the Mullerian system, some remnants of the uterus or infantile uterus or something. Then you it's an MRK syndrome. So this is different types of Mullerian anomalies. Like Didelphys, you can see the fusion is very incomplete. It's like just beginning to fuse only, kind of like just getting together only. Unicornate, like we said, there is it is a partial agenesis. One side is not developed properly. Okay, then arcuate septate, over the septate uterus, that is when the resorption is not happening, and bicornate is when the fusion is incomplete. This is not in order. As we go, you can see that there's a different style where it comes in order. Okay, so this is a class 2, that is unicornate. So first thing we talked about is the fusion, not fusion, developmental problem, right? We do not have we had an organogenesis problem there, MRK syndrome. Now second is also an organogenesis problem, but only thing is only one side develops properly, the other side does not develop properly. So there may be complete or almost complete arrest of development of one Mullerian duct. If the arrest is incomplete, as in 90% of patients, you might get a rudimentary horn. So that is what happens. You get a unicornate uterus, that's a one functioning horn, which is kind of well developed, one half, and the other half is undeveloped or very poorly developed. So that will present as a rudimentary horn. Now the rudimentary horn sometimes can have endometrium in it. If it has endometrium and it bleeds, and there is no place for the bleeding to go, if there is no communication to the existing normal horn, then what happens is it can form a hematometra, and it can present as a cyclical abdominal pain and enlarging pelvic mass. If the contralateral healthy horn is almost fully developed, then it will be just a normal full-term pregnancy. You will not even know that there is an anomaly. That does happen. That is why we say that many of the times we don't know what is the exact incidence of Mullerian anomalies. So that is an HST picture, I think hysterosalpingogram picture of a unicornate uterus. As you can see, the dye has gone and it is shown you clearly one hemi-uterus. You can see only one side of the system is developed. This is a laparoscopy picture where you can see the first picture, figure 3A. There is a left, you can see the rudimentary horn is there, and the right horn is the developed horn, left rudimentary horn, but kind of the tube is developed. That's why it's a different phases of development of the horn. The rudimentary horn. Sometimes even the tube and ovary may not be there. The other side you can see, this is another picture where you can see the right tube and ovary is not present at all. This is another picture, okay, not the same patient. This is another picture where you can see the right unicornate uterus and with tube and ovary. So you can see the tube is the tortuous structures that you see is a pampiniform plexus behind the tube, the right tube. That is a pink, the violet, very tortuous structures you can see there. This is the right side of the right tube and the right hemi-uterus, or the right unicornate uterus. Okay, so this is more in order of the developmental abnormality. As you can see, the first picture is hypoplasia or agenesis. So you can see it can be different types of agenesis, maybe vaginal, maybe cervical, fundal, tubal, combined. Any of those, partly or completely, they can be agenesis. Now unicornate is when one half is developing properly. There is a second one. So that is A, B, C, D. You can see where you can see the different, the varying degrees of non-development of the other horn. So one horn is developed properly, unicornate uterus. Now what happens to the other horn? So D, you can see maybe there is no horn. There can be no horn on the other side. C, you can see there's a horn. There is a rudimentary horn, but there is no cavity. So just a mass there. It's not going to create much trouble for you then. Now B, you can see is a non-communicating horn. Now what happens to the non-communicating horn is if there is an endometrium, it's going to bleed cyclically. It is going to undergo all the changes that your normal uterus goes through. That collected blood has no place to go, and that is going to form a pelvic mass. That is what we talked about earlier. Now A is a communicating horn. Now communicating horn, it will bleed, so there may not be a problem with the abdominal pain and mass may not form. Only problem is if it is a communicating horn, sometimes the embryo can get implanted there, and what will happen is you will get a pregnancy there, which is not going to be sustained by such an undeveloped horn, and that will present as an ectopic pregnancy, can rupture with a lot of hemoperitoneum, can be very life-threatening case. So that is the 4 types of unicornate uterus. Now 3 is Didelphys. Now Didelphys, what has happened? your first part is over. That is, your organogenesis is complete. Both the horns have both the Mullerian systems have developed properly. Now we are coming to the second part. Are they fusing properly? So the fusion is just not happened. It has not happened. It is really not come together. It's just coming little close together only. It is not fused at all. So that is uterus didelphys. Now part 4 is, you can see the next stage is when or the next type is when the organogenesis is proper. Both the Mullerian systems have developed properly. They have started fusing, but the fusion is not complete. That is when you get a bicornate uterus. So it can be complete or partial bicornate uterus. And next would be a septate uterus. So septate uterus, again, your organogenesis is perfect. Both the Mullerian systems have developed properly. They have come and fused properly, but they have to get resorbed. The septum between, it's not just enough to fuse, right? The septum that is formed in between has to get resorbed. Only then you will get a single cavity. That single cavity is not may not be complete because of this because of the resorption not being complete. That is a septate uterus. And then you can get, next step is when everything is normal, but just one small indentation, one small fibrous mass might be there. A fibrous bit might be there. It is not going to create much of a problem. That's your arcuate uterus. And your 7th class is DES, drug-related problems. Okay, diethylstilbestrol problems. We talked about earlier, right? It was given in for prevention of abortions and preterm labor, but ended up having some uterine abnormalities. Those kids ended up having teratogenic exposure. Okay, I'll go back to the didelphys uterus. So remember those pictures. This please keep this picture in mind. This is gives very clearly. It shows you the progression, like from the formation, organogenesis, fusion problem, resorption problem, so it is, this is an important picture. Okay, now class 3, didelphys uterus is results from complete non-fusion of both the Mullerian ducts. The individual horns are fully developed and almost normal in size. 2 cervices will be present. That's why I said there's no fusion, so even the cervix is normal, will be 2. And the didelphys uterus at the highest is between transverse vaginal septa. Mostly you may not need to treat them because both the hemiuteri are fully developed, so might carry on till term, so may not require treatment at all. That's a picture of didelphys. Okay, so this is a double uterus in ultrasound. You can see very clearly 2 uterus. Okay, two bumps, you can see 2 uterus, and it's not connected at all. You can see very clearly there's a distance between the 2 uterus. This is another picture MRI of another patient who has, you can see very well that U and U, you can see 2 U's shows very distant, it is 2 hemiuteri which is not fused at all, and that P shows the vagina of that one half of the uterus which has got filled with pus. That is because it is the vagina is also not canalized properly. That side there might be an imperfect there might be a vaginal septum there on that side, whereas the other side vagina is normal, seems to be normal. That is written as V. Okay, it's compressed by this pyocolpos. Now we come to class 4. There is a bicornate uterus. We said everything is perfect. It is not as bad as a didelphys. It has started fusing, but the fusion is not complete. So partial non-fusion. It can be bicornate unicollis or bicornate bicollis. Bicornate unicollis means you just need to know this. Okay, I don't think you need to know in detail about how to differentiate between all these. Bicornate unicollis means you have one cervix. Unicollis one cervix. Bicollis means 2 cervices. So the septum has been formed. It is fused, but it's fused, but the central myometrium extends to the level of external cervical os. So the differentiation, you really don't need to know this. Okay, now this is a bicornate uterus with unilateral pregnancy. As you can see, compared to the previous picture that we showed of a double uterus, it's not that separate. You can see the fusion has occurred. Okay, there is a fusion, and you can see that it is partially fused, but you can see the contours very nicely. You can see the contours of the 2 hemiuteri, you can see, but it's not that separate from each other as it was in the previous picture. This is another histopathology, this thing, gross specimen, where you can see one horn which contained a pregnancy in the sac, and the other horn which is a normal horn. Okay, so this is a bicornate uterus. Clearly a bicornate uterus where one horn looks bigger than the other horn because it contained a pregnancy. That is why one horn looks bigger than the other horn. Now, class 5 is septate uterus. So, this results from failure or resorption of the septum between the two uterine horns. So, the septum can be partial or incomplete, and that histologically can compose of myometrium or fibrous. Okay. So, they have the highest incidence of reproductive complications. Septate and biconate is the most common type also that we come across. So, you can see the contour. Like, you see it's a rounded contour. Only inside you can see one septum and two cavities. In one cavity, it is there's a pregnancy. There is a pregnancy in the cavity. So compared to the previous picture, where this picture, you can see the indentation, right? It's not this is smooth. It's like two cavities, but nice, smooth, rounded contour. And this you can see very clearly because it's a pregnant uterus. Because it is distant by pregnancy, so you can see very clearly. So this is the ultrasound parameters of a septate uterus. Okay. Now differential diagnosis it's important to differentiate between septate and biconate uterus also. It's because the treatment is different. For septate uteri, what you need is, you have just a septum there, you just need to cut that septum. Everything else is perfect there, just that septum is there. If you can get rid of that septum, by and large should be okay. Whereas in case of biconate uterus, if you cut that, you're just going to go and perforate through this is your biconate uterus, right? So you can't just cut that. You can't just cut that because till where will you cut? You need to do a metroplasty. You need to reconstruct the you need to join together both the horns because the fusion is incomplete. Now you have to do a fusion. Operatively, you have to do a fusion because genetically, embryologically, the fusion has not occurred. So that would need an abdominal approach. So for a septate uterus, it is just a fusion is complete. You just need to do the resorption. That you can do. You can just cut off that septum vaginally by a hysteroscopy. You can do hysteroscopically. You can cut off the septum. Whereas in biconate uterus, fusion has not occurred properly. So you need to complete the fusion also by an operation. So you have to do a metroplasty. For that you have to do an abdominal operation. So in biconate, the fundus is indented. There is a variable degree of separation of uterine horns. It can be complete, partial, or minimal. Your reproductive problems may be minimal, but they can have pregnancy loss and preterm labor. HSG may not completely diagnose. You may need a laparoscopy. That's because HSG will only tell you about what the inside picture is like. You need to know what the outside contour is like. Like we saw in the ultrasound, we saw how the contour is very different in the biconate and the septate uterus. That's because the pregnant uterus again that we could make out the contour differentiation. If it is non-pregnant uterus, it will not be so clearly demarcated, and that is and many of these women are going to come to you with infertility. So that is why HSG may not be enough to help you diagnose whether it's a biconate or a septate uterus. So if you need to make a distinction, if you need to do a septal resection or whatever, decide on what you are planning to do, you need to get a proper diagnosis. HSG may not be enough. So in septate uterus, there will be normal external surface. Again, like the biconate uterus, to differentiate between septate and biconate, you need laparoscopy. The septum can cause infertility, recurrent trimester loss. Okay, now class 6 is the arcuate uterus. So this is the endometrial cavity demonstrates a small fundal cleft or impression. This is by and large a normal uterus. There's nothing much wrong with it, just that you get a small fundal cleft. Okay, and so it's not associated with any increases of pregnancy loss or any other complications. It's just a normal variant kind of thing. It's just a mild thickening in the midline. Because it is not associated with any obstetric or gynecologic complications, it can be considered as normal. Okay. Now, class 7 is DES related abnormalities. So, they can occur in the female offspring of as many as 15% of women exposed to DES during their pregnancy. So, uterus there can be hyperplasia of the uterus or a T-shaped abnormality of the uterine cavity. And cervix can have abnormal transverse ridges, hoods, stenosis, and the vagina can have adenosis with increased risk of vaginal clear cell carcinoma. So, these are the problems of a DES related female fetus which has been exposed to DES. Okay, so myometrial hypertrophy resistant T-shaped uterine cavity and cavity irregularity, which is pathognomonic. This is a T-shape. This is an HST showing the T-shaped deformity of the uterus with normal fallopian tubes and filling of dilated glands or cervix. This is another classification, T-Lindsay. You don't need to know this. This just tells you like according to the organogenesis fusion defects type. In that order it comes. Okay. Now coming to the clinical presentation. So clinical presentation, sometimes newborns might come to you. You might diagnose an Mullerian anomaly in the newborn or an infant, or it can come to you, present to you in the adolescent years, or might come to you in the childbearing age with infertility or repeated spontaneous abortions or preterm labor. So if it's a newborn infant, it is due to mucus collecting. Okay, so it's a mucocolpus. So there might be a palpable abdominal, pelvic or vaginal mass. So that is how a newborn infant might present. An adolescent girl might will present with a delayed menarche or maybe cyclical abdominal pain. Delayed menarche, if it's a complete imperfect hymen or something, then or it can be an MRKH. She's developing normally and then no menses. She'll come to you with primary amenorrhea. So if it's an MRKH, or if it's an imperfect hymen, then if it is a unicornate uterus with a communicating rudimentary horn, non-communicating rudimentary horn, then there can be blood collecting cyclical abdominal pain. It can become a hematometra, become a mass there. Okay, so those are the varying presentations that they can present to you in the 3 different age groups. Women can come to you. Now coming to investigations, what are the investigations that are available in gynecology? You can have an ultrasound, which is you can do a transabdominal ultrasound, transvaginal ultrasound, and of which TVS, if you can do a 3D, it will be very good. 3D will have a higher sensitivity and specificity. Now HSG can be done, but again we said that HSG is only going to tell you about the inside of the cavity, doesn't tell you how the outside contour is. So if everything is by and large normal, then maybe we can avoid and we can say maybe there is no uterine anomaly. But if you're finding 2 cavities, then you need to know what kind of anomaly. Is it biconvate, or if it is septate uterus, then you might have to go in for a laparoscopy to know. Or nowadays, of course, you have MRI which will diagnose properly, will give you a good idea. Okay, and sometimes it may not be possible to perform this HSG because there might be a vaginal agenesis there and you will not have access into the cavity. MRI is a standard for imaging uterine anomalies, high resolution images. Also, the advantage is that you can also look for urinary tract anomalies because we said they are developing together. These are mesodermal components. Both are developing at the very close to each other. So we know that urinary anomalies are more common in Mullerian anomalies. So you can look for that also. And most types of uterine anomalies can be diagnosed. MRI is the most accurate, followed by TVS and HSG. Hysterolaparoscopy is usually used when you think that you can offer a treatment at that sitting. You can find out as well as offer a treatment. If there is a maybe hysteroscopically you can do a resection of the septate uterus, or maybe you can do a metroplasty or something. Then that is when you go for a hysterolaparoscopy. Management, so that depends on the severity of the menstrual, fertility and sexual function problems. Some of them may not require any management, right? If she's got a biconvate uterus, she's getting pregnant, she's having she's able to complete her family, doesn't require any treatment. So it depends on the presence and severity of the problems and the type of anomaly. So again, like we said, unless there is a symptom, you don't have to treat it. And some only you can treat, you cannot treat anything. The type of abnormality also will guide. Many assisted reproductive techniques might be used. ART might be used for reproductive functions. Otherwise, what we generally can offer is a uterine septum hysteroscopic resection, vaginal septum simple resection. If there is an absence of vagina. Now this is the major surgeries that is done in reproductive tract anomalies. So the management as such, like we said, if you look at the treatment, if there is no vagina, you might have to create a vagina in case. So that's a major surgery. You have to go in with dilators. It's not a one-time procedure. It requires many sittings and all that. Then the other surgeries that you can talk about is in the biconvate uterus and in the septate uterus. So we'll come to those two after this. So in case of absence of vagina, neovagina creation can be employed initially. You have to do some non-surgical methods to create the space there for surgical procedures. McIndoe's space is dissected between the rectum and the bladder, and a split thickness skin graft from the buttocks is used to form the vagina. And the dilator is put at the time of procedure to create continuous dilatation of the vagina while the graft heals. And then you keep dilating it. The patient has to come to you repeatedly, maybe weekly or 10 days to 2 weeks like that, to make sure that it doesn't close out the vaginal cavity. Other procedures like Williams vulvovaginoplasty uses full thickness skin flaps from labia majora to create a vaginal pouch. And you can also use musculocutaneous flaps and free intestinal grafts. The intestinal grafts are very popular actually because mainly done by pediatric surgeons generally, used to be at least. Nowadays, of course, this is to create a neovagina. So you can use, only problem is the intestinal glands are there, so you can have copious mucus secretions from those glands. So decision is dictated by the patient's characteristics and needs. Now, if the uterus will support, then you can do an IVF cycle. If it is a uterus which is well formed and will support a pregnancy, you can do an IVF cycle. You can implant the embryo there, and she can have a cesarean section. Otherwise, we told you, we spoke about, we discussed it. You can go for an IVF and implant the pregnancy in a host uterus if the uterus is too small. Okay, if fertility is not an issue, hysterectomy might be done. Then the other two procedures that we talked about is that when we talk about treatment, so one is creation of neovagina through all this. Then second is the artificial reproductive techniques which can help out, which can aid the reproductive requirements. Then third is metroplasty. Metroplasty is done for bicornuate uterus. So you can see this is a bicornuate uterus where metroplasty will be done. So that's a laparoscopic picture. Now that is the triangle is the area where they'll resect to stitch it together. They'll resect that area and they've sutured that together. So reconstructed uterus contraction suturing, and this is the hysteroscopy after metroplasty. So there's a third procedure, metroplasty. Now fourth is hysteroscopic resection of a uterine septum, which we discussed before. So I'm just putting it together now and telling you. So that is the fourth procedure that you can do. Then other procedures that you might have to do, sometimes you might do a resection of the rudimentary horn, depending on whether it is a problematic. Of course, if it is going to present to you with an ectopic pregnancy in that rudimentary horn, which is rupturing or whatever, you will definitely remove it. If it is a harmless rudimentary horn which is not presenting with anything and which is just found at the time of surgery or something, you might leave it alone. So that depends. Like that is other surgery which can be done as such. Okay. So mainly that is to remove it when it causes a problem. Otherwise, these are the problems. And of course, for an imperforate hymen, you can put a cruciate incision and to make it a patent this thing. And we talked about the septum. If it's a vaginal septum, you can remove it. Okay. So this is the assignment. I will send the link to the Google Classroom. So please submit your assignments. Okay, thank you.